full disclosure, I am the CEO, proud CEO of Fluids IQ. And that's important because we actually use all these three platforms for various tests. So, because of that, it's important to understand that each one has its advantages and its disadvantages. And I think that one needs to be cognizant of when is it best to use one as opposed to another. And so you need to factor in many different things. And amongst them is everything from what are you looking for? What's the cost effectiveness? And so on. And before I put on the slides, the other thing that I wanted to mention is that we also need to separate doing testing for adrenal hormones as opposed to what we call the sex hormones. And you'll see in just a few minutes why one needs to really separate that out. So I'm going to just open this up, and if people can't see it, let me know. But at the present time, what you're looking at here is the front slide, which is really going to be talking about a comparison of blood, saliva, and urine mediums or platforms for testing, specifically for hormones. And as I've said, one needs to always know, why are we testing? I'm not going to go into a long discussion of why to test. I think that all of you in FDN have a pretty good idea that you do require objective evidence that's going to back up the kinds of things that you see clinically. And unless you have that, then it's like a shot in the dark. You really don't know what is going on in the fullest way. And so testing in and of itself is critical. And of course, why should we use one matrix as opposed to another? And I'm using the word matrix because you're going to see that term used quite often in the literature. And a matrix really represents the sample medium itself, the blood, the saliva, the urine. It's not really talking about the analytes that you're going to be looking for, but what is the medium or the matrix? And thirdly, which is the best? So when you say which is the best, the question is, what kind of answers are you looking for? And what kind of questions do you need to ask to get those answers? And so we're going to try to really get through a lot of this. And remember, what we're talking about today is steroidal hormones. We are not discussing many of the other tests that one can do in these various mediums. We're going to be concentrating on steroid hormones, hormones in the adrenals, hormones that are produced as sex hormones. And many of you are very familiar with this classic flow chart, which starts, of course, with cholesterol and brings you to what's called the mother hormone or pregnenolone. For those of you who are in the field, you'll know that from that pregnenolone, you can go to the progestogens, which is mostly progesterone, and you can go to DHEA, which then is going to form many others, testosterone, which is one of the androgens, or the whole series of estrogens, including E1, E2, and E3. And we're going to be discussing specifically estradiol 17 beta. And when you're looking at progesterone, for those of you who know about this, you'll recognize that it will eventually form the glucocorticoids, the most important one being cortisol, which can then be broken down enzymatically into a storage level called cortisone. And of course, there is also progesterone's ability to also create the corticosteroids, the mineralocorticoids like aldosterone and so on, which is a whole different area that we're not going to be going through in great detail. But if you say, oh, okay, I know these pathways, well, there's a much more complex series of pathways, and that is looking at what happens when these steroid hormones are metabolized. And they're metabolized in many different places. They can be produced in the adrenals or in the testes or in the ovaries, but then they are metabolized in the liver and eventually get into the urine, where there are many tests that can be done in the urine, which gives you not only the particular entities I discussed a few moments ago, but also all of their metabolites. And the question is, which we'll go into in more detail, what do you need to know when it comes to the metabolites, and why do you really need to know that? In order to assay or to look at these various types of hormones and their levels, if you want to measure them, there are two general groupings of test profile modalities that you can use. One is under what we call the immunochemical assays. And you've seen some of these acronyms: RIA, ELISA, FIA. ELISA is probably the most famous of them, and that's an enzyme-linked immunosorbent assay. It looks at the way in which various types of antibodies are going to react with the antigens and will give you some pretty good sensitive results. The second way is with gas or liquid chromatography technology, most often combined with mass spectrometry, which is called GCMS, and we will talk about that in a few moments. So immunoassays, of which there are multiple forms, is an analytical method, and it's important to remember that it gives you an analytical result. It'll give you a number, and that's what most of our results that come out of our lab are, as they are with most labs. We give you a particular analytical result, a number. And as I said, it uses antibodies as the reagent that allows you to quantitate the various analytes you're looking for. And I'm not going to go into detail on this. We can do that at some other lecture where we go strictly through immunoassays for those who would like to know. But the second way is GCMS or GCMS.MS. There are a whole number of different kinds, and this is either gas or liquid chromatography. These assays are quite often coupled with mass spectrometry or a tandem form. I'm not going to get into the details, but the bottom line to all of this is that it is an extremely sensitive way of looking at all of these different analytes. It is probably the gold standard in many cases, and it's called molecular fingerprinting. What you really do is you take gas or liquid chromatography, in which what you're doing is you are creating, with various types of heating systems, you're creating a dissociation of these analytes, and you're looking for the particular temperatures where they will precipitate in a column and are able to therefore be spaced out, and you're able to start separating all of those. And when you mate that, when you bring it together with mass spectrometry, what you're really able to do is to create a fingerprint to actually be able to see each one of these compounds or individual molecules. And it is extremely sensitive, and I'll say right away, it can be very time consuming and can be extremely costly. So when you're looking at steroid testing, let's be very clear. Endogenous, that's what is produced by the body itself. All three of these main fluids, and even within them there are changes. We're talking about blood, which can be serum, plasma, or dried blood spot. That's called blood. Or saliva, that's number two. Or urine, which can be either wet or dry. All of these can monitor the endogenous primary active steroid. That's what is produced by the body itself. And we know that accuracy can be an issue because some of these steroids are at very low levels. So that is going to tell you what type of modality you should be using depending on what you're trying to find. Some of the sex hormones come in very, very small measurements, very, very low levels, and you need to know that you have a platform that can pick up those low levels in an accurate and predictable way. So we do know that when, for example, you're testing endogenous sex hormones in the serum, it's very well characterized in the medical literature, and it is less so in urine or saliva, or for that matter, whole blood that comes in the capillaries. That's what dried blood spot is. However, when it comes to exogenous, meaning when you are giving various types of steroid hormones to the body, not all of these three fluids are appropriate for the measurement of these types of exogenously delivered steroid hormones. And that is specifically a problem when you start delivering these hormones orally or through topical administration, which, as you know, is the way most female exogenous synthetic hormones are offered. So let's take a look at the relative merits of the three primary analytical matrices that we use to test hormones. And we're going to look first at blood, and I put in brackets serum because that's the way we normally think of taking blood tests. When someone goes for a blood test, they're normally going for a serum test in a hospital, in a large outpatient department, or when it's being done through phlebotomists. And what are we looking at? Well, when you're looking at steroids, or for that matter, many other types of entities in blood, you're looking at both the bound and the free steroid. Now, what does that mean? Well, the free steroid is sitting in the blood, but very quickly, most of it gets bound up with various other proteins, which become the carriers for that particular steroid entity. You can have non-specific binders like albumin, which is a ubiquitous protein that is going to bind a lot of these. Or in the case of the sex hormones, it can also be bound up with two other types of proteins, the sex hormone binding globulin, which specifically binds the estrogens or the androgens, or the cortisol binding globulin, which is binding cortisol and progesterone. And we'll see why that's an issue in just a few moments. So as I said, we're going to be looking at advantages and disadvantages of all of these mediums, and they all do have those problems and advantages as well. So what are the advantages of serum sampling? And remember, I'm looking at serum now, not blood especially, but serum aspect of blood. Well, the advantages of serum sampling is that it's readily available. Any hospital, any outpatient department can test with blood in order to get the serum. It can be cost effective for many different types of analytes that you're looking for. We know that it's extremely well established in terms of its reference ranges, and it is widely utilized, and it's quite accepted. So we do know that blood sampling, especially serum, is ubiquitous today. And it does measure both the sex hormone binding globulin and the cortisol binding globulin. And it's ideal for testing peptide hormones. Now, these would be things like thyroid hormones. So you're including reverse T3, T4, all the different thyroid hormones, follicle stimulating hormone, LH, prolactin, you name it, any number of different peptide hormones. And these hormones, because of their molecular weight alone, which are quite large, do not appear in the various filtrates that you would get in saliva or urine. So that's where serum sampling is very important. But it has disadvantages as well. Hormone concentrations are time dependent. In other words, they are really going up and coming down in levels very quickly, hour by hour, which is called ultradian, or diurnal, which you're familiar with, what goes on over a period of the waking hours of a day, or circadian, which is looking at daytime versus the middle of the night kind of a periodicity. And so you need to keep that in mind. And these are rapidly cleared, so they have a very short half-life. So when you have an analyte like a sex hormone or some of the adrenal hormones, which are pulsatile, in other words, they're coming out very quickly and disappearing very quickly, that will cause a problem if you need to test with serum for obvious reasons. You can't have a person sitting there with a needle in their arm for hours trying to find out what's going on. And serum, by its nature, for that kind of testing is invasive. You do have to put a needle in someone's arm. And so it is an invasive collection process. And we do know that there is, in some cases, a pretty poor specificity for some of the immunological based assays when it comes to certain types of sex hormone assaying. And that has really come to the fore now that we know that you can use various types of GC and mass spectrometry, which gives you a vastly improved specificity. But of course, as I said, with significant additional expense. So it can be very cost prohibitive. But I do want to, again, make sure that you understand that serum, like anything else, when you do a spot test, is providing a snapshot in time, what is happening at that moment. Now, if you have rapid fluctuations in the serum of many of these sex hormones, then it makes repeat testing necessary in order for you to have some idea of what's going on during the day. That is inconvenient, to say the least, if you're doing it with blood testing, and can therefore be cost prohibitive. And if you're going to do that, you're going to also have to look at separate tests that are going to show you both the total hormone which is being picked up, that means the bound and the free portion of the hormone, and that in and of itself is an issue. So when you're looking at utilizing serum for bioidentical estrogens, which are used in hormone replacement therapy, be they the estrogens, progesterone, the androgens like testosterone and DHEA, most of the time they're used orally as a form of HRT, which is hormone replacement therapy. And what you need to know, this is quite important, is that you need to dose 10 times the physiological level in order to achieve a physiological level of the active protein, simply because of the way in which what you're adding to the body, the way in which the body interacts with it, the way in which the gastrointestinal system and other parts of the body break it down, you may end up with very false high hormone levels in serum from what is actually going on. So most commercial serum immunoassays that rely on various types of polyclonal antibody assays overestimate the true levels of, for example, progesterone, especially for those women who are on oral progesterone therapy. So right off the bat, you got to be careful. And it has a limited utility for sex hormones for what I just mentioned earlier. There is no distinction that is made between the bound up and the free hormone. Remember, I told you there's free and there's the stuff that's bound up with various globulins. So you end up getting a report of the total hormone. And free hormone assays, by the way, are very uncommon. And so you're mostly getting the total hormone, which can be extremely misleading. So if the free hormone level is low, a patient can be functionally deficient, even though if you're doing only serum testing, you're looking at the total hormones. You're saying, oh, the total hormone level is fine. Well, that may be fine, but the amount of free hormone that is bioavailable, that is bioactive, that is actually being used by the body can actually be quite low. So one needs to be very careful with that. I'll be giving all of you a PDF of this, and so I just added these for you to be aware that you test in the case of sex hormones for estrogens, the 3 different types, the progesterone, and as well the testosterone. And I think it's also important to recognize that serum hormone testing does not measure the metabolites of estrogens, androgens, or adrenals. So if you're looking for metabolites if that is something that you need to do, and I'll go into that in just a few minutes, then doing serum testing for any of these hormones is probably not the best thing to be doing, to say the least. And last but not least, in the case of serum, we always seem to use the term blood synonymously with serum, definitely in the medical establishment. But remember that you can be using dried blood spot as a modality. That's what we do at Fluids IQ when we're looking at some of the tests that we do, and I know that some of you already use those. The advantages of using dried blood spot is, of course, that it's much less invasive than serum. All you need to do is just lance a little finger and you get a little bit of blood, and from that you can get results. So it's much easier and much more reliable as a transport issue, because you're transporting some dried blood on a card, and that stays quite stable over long periods of time in the mail, etc., unlike serum in a tube. And it also allows for home testing by the patient, and as well testing in offices that don't have phlebotomists, or for clinicians who do not have the right to be doing invasive phlebotomy testing. The disadvantages of it is that it's a tissue level test. It tests the blood that's in the capillaries, and so you need to be careful when you're originally doing this work in a lab that you can correlate the levels that you're getting from blood in the capillaries, which is what's coming out on the tip of a finger, and how that compares to the levels in serum. And that is not always obvious, so you do need to know that. And remember that you're using whole blood when you're doing dried blood spot, so any lab that gets involved in this has to really know what it's doing, because there's the hemoglobin effect, there's the coagulants that are there, and all of that has to be understood in order to get results that make sense. So that was just a quick overview of serum. Remember, I'm just giving you an overview. What about saliva? Well, unlike what I mentioned before with blood, which gives you the bound and the free steroids, saliva, interestingly enough, only picks up the free steroids, because the steroid that's bound up with the various types of proteins cannot get through the salivary gland cells or between the cells. So either by passive diffusion or active transport, the only thing that gets through are the free steroids, meaning the steroids which the body has available to it to actually utilize. And that only represents about 2 or 3%. And so just remember then that whether it's endogenous or exogenous produced hormones in the bloodstream, 97 or 98% of the active hormone is bound up and therefore cannot be used. So it's only 2 or 3% that can be released into the capillaries and then into the interstitial space and the tissues. Given that you understand that, in saliva, most of the metabolites from oral hormone therapy are filtered out by the salivary gland. So, as I said, only the active hormone enters the saliva. So, here I have in bold, salivary hormones are much more representative of the amount of bioactive steroid that is present in the bloodstream, and therefore that is bioavailable to the target tissues. So just knowing what the total amount of the hormone is quite often quite unrepresentative of what you really want to know. So saliva, as an advantage, it's clearly an excellent medium for rapid testing, because it happens literally in seconds. You can get those values very quickly, and it can accurately measure clinically validated biomarkers. It's been around for decades, and we now know how to handle it well, but you still need a lab that has experience in saliva testing. It's relatively non-invasive, and it measures, as I said, the free hormone fraction. So it's ideal for multiple or serial sampling that you want to do per day. And I'm going to jump right in and tell you that's the reason why, if you're looking at doing diurnal cortisols, if you want to see what's happening to cortisol levels during the day, the standard for that is saliva testing. And one can look at all of these different things, which I'm not going to go into detail, but with saliva, you can be looking at all of the different levels, the estradiol levels in females, the small amount of in males, the testosterone small amount in females, the high amount in males. You can be looking at all of that in saliva. And with the female sex hormones, you can be looking at the way they change over a period cycle in the month. So you can be doing levels throughout the month if you want to. As you know, there are various ways of doing that. But with saliva, you can actually go through a whole cycle, and you can do it in a cost-effective way. But one of the best ways for it to be used is for cortisol. And I'm just putting this up as a classic example of normal cortisol when you look at a diurnal daily rhythm where you have the highest level in the morning, as you know, and then it moves down in a curve during the day, ending up in the evening at its lowest levels. And it's very important to look at this diurnal cycle because it tells you whether or not the system is acting properly. Also, it is extremely important for looking at stress measurements because given that you can be doing measurements every 5 or 10 minutes if you need to, you can take a look at the response of an individual to various types of stressful situations. And it is the classic medium to look at cortisol levels during stress. No question asked. It is by far the best way to do it. And of course, with chronic stress, the same thing. You can look at the classic stages, stage 1, 2, and 3, in which cortisol over-responds due to chronic stress, moves through a decreasing amount of cortisol as well as pregnenolone and DHEA in the second stage. And the third stage, which you would rather not be in, is a non-responsive stage when cortisol is flatlining, meaning that the adrenals are just not producing the amount that they need. And we can look at these daily profiles. In red is the cortisol level starting in the AM, as I said, and then moving down over the day. And I've thrown in here melatonin, which has its peak in the middle of the night and then comes down so that by the beginning of the morning, it is already at a very low level where it stays for the rest of the day. Why am I mentioning that? Because as Jennifer has mentioned to you, we at Fluids IQ are now going to be offering to FDNers in Canada, internationally, and in New York, and hopefully to more in the near future. We're going to be offering what we call our Female Wellness Daily Cycle, which gives you the estrogens, the progesterone, testosterone, the 4 cortisols, that is diurnal, the DHEA, and the melatonin in the daytime. Actually, it's the noon sample for melatonin. We'll go into that in more detail. And there are disadvantages. You need to understand that saliva production is quite difficult for some patients. And so if you've been eating, if you've been drinking, if you've been gum chewing, you name it, that can affect the results. If you have periodontal disease, it can affect the results. If you are over the age of 40, you start decreasing the amount of volume you can produce at any given moment in time. If you have Sjogren's syndrome, especially females, they start developing dry mouth. They cannot give you the saliva that is necessary. And so that could be a real problem. And as I said, it is best for steroid hormones. It is not a good medium for peptide hormones like growth hormones or thyroid, as I mentioned a little bit earlier. And metabolites of steroid hormones are not measured in saliva. And we're going to go over that when we discuss urine. So there are issues, some more issues, which are sensitivity and specificity. In some cases where you're doing non-antibody based assays, you can have some analytical sensitivity problems. You can get a little bit of cross-reactivity. I'm jumping through this simply because if you have a good saliva lab, they are not going to run into these problems. But for the purposes of completeness, yes, if a lab is not doing it properly, they can run into a lot of problems with this. What I do want to go over, though, is urine, and I think it is important to look at this. And I'm going to repeat again before I go over this. Fluids IQ does urine, and in fact, we do dried urine testing. As many of you know, we offer the metabolic wellness profile, which includes a test for digestion, for liver detox, and for oxidative stress. But these are looking at analytes which are very different from the type of hormone analytes that we're discussing here. And in order to look at what happens in urine, you need to remember that steroids are metabolized in the liver, like almost everything else. And so you need to think of steroids that are in blood, that go through the liver and go through the classic two phases of liver function, which is phase one, breaking it down with any number of reactions from oxidation, reduction, hydrolysis, etc. And that creates an intermediate metabolite. And then, of course, you have all of the neutralization functions in the conjunction pathways of liver, which eventually lead to the excretory product that comes out of the liver. Those are the water-soluble derivatives which end up in serum and eventually go through the kidney into the urine. And that's what you're seeing when you're looking at any of the entities we're discussing today, when you look at them in urine. But you need to remember several things. Number one, urine in general has been less common in clinical practice than either serum or saliva, for that matter, when you're talking about hormones. And for the most part, when in the medical community you're talking about urine sampling, you're looking at 24-hour urine collection. I'm going to repeat that, 24-hour urine collection. It is the preferred method for testing hormones that are secreted at night, during deep sleep, like growth hormones, etc. And it is by far the most economical and reliable way to evaluate metabolites of hormones. But remember, you have to differentiate 24-hour urine collection, which we call wet urine. You're literally, peeing urine into a big bottle. And you need to differentiate that from doing dried urine or serial single point collection. And we'll get to that in a few moments. So what are the advantages of 24-hour urine, of wet urine? And you need to look at that first before you can discuss dried urine. Number one, they measure, just like with saliva, they can measure the unbound. That's the bioavailable hormone fraction. And there's very little cross-reactivity. It's really the gold standard when you look at what is accurate and reproducible. And that is normally done with GCMS, with gas chromatography and mass spec. So in clinical practice, we use 24-hour urine hormone profiles, and they correlate very well with the symptoms that are reported by patients when they're doing questionnaires that you are trying to correlate together with the results you see on paper. So it is allowing us to evaluate the adequacy and even the safety of giving various types of exogenous hormone therapy, estrogen supplementation, etc. So 24-hour urine, therefore, in the various panels that you can get it, is excellent for evaluating adrenal health and its function. And it's as they say, virtually 100% specific when you're using GCMS, which is wonderful to use, but as I said, it's very, very cost prohibitive in some situations. So I I need to make sure that this is very well understood. When you're doing 24-hour urine, there are disadvantages. The first thing is it's very inconvenient. Compliance is often very questionable, and that is a problem in and of itself. In fact, there are many physicians, when they're doing 24-hour urine, that will do it in an in-house environment, meaning literally a place where they know that they can control the amount of urine that is coming out so that there is no question as to the urine flow and the amount that they're actually collecting, and they don't depend on what the patient or the client has told them. The results can also be altered very significantly in patients that have problems with liver and renal function. If it's impaired, that can put in doubt any type of result you're getting in 24-hour urine. For example, dehydration, or if you're doing excessive fluid intake, that affects the results. It affects the creatinine, which I'm not going to go into detail, but that is a key protein that you need to be aware of when you're actually looking at urine results. So because of that, you can run into problems. There's another major problem, and that is fundamental misinterpreting the results due to the liver function, the hepatic first pass, as it's called. In other words, if you're doing oral hormone replacement therapy, those oral therapies go through the gut, then through the liver. It's completely adulterated by the time it gets into the urine. And so you really need to know what has been used as a way of giving that individual the hormone therapy in order to even begin to understand what the results are telling you. And it does not elucidate, I'm talking 24-hour urine, does not elucidate diurnal cortisol patterns. And so when you're looking at that, urine testing and hormone supplementation then have a whole series of issues that you need to deal with. We know 24-hour urine reveals approximately the total amount of hormone that was consumed and eliminated, but it doesn't really tell you what's in the systemic circulation necessarily of bioactive and available hormone that is entering the target tissues, because it's a combination of what has come into the urine, which is bioactive, and the metabolites. So we do know that urine testing is an excellent way to evaluate endogenous production produced by the body of sex hormones, but it is not clinically useful as a diagnostic fluid for exogenous oral or topical hormone delivery. And remember, most delivery of exogenous sex hormone therapy is done the oral or topical route. So that puts urine into question. And then there's a much bigger issue, and that is dried urine tests. And I'm going to be very careful and diplomatic in the way in which I discuss this, because I want to make sure everybody understands this. So like all spot testing, whether it's urine, saliva, and so on, there can be fundamental flaws and compromises because it's a snapshot in time rather than a full representation of a 24-hour production cycle. So you need to know what's the question you're asking and what do you want to come up with. So because results, when you're doing dried urine spot tests, cannot be expressed in the classic microgram per 24 hours, etc., which is eliminating the urine volume as a variable, because if you're doing 24 hours, you know how much urine you actually had. If you're not doing that, then you have to normalize to something in the urine called creatinine. And that creates a whole slew of problems when you're doing what's called pulsatile analytes. Those are analytes that are changing very quickly, like steroid hormones, because creatinine levels are going to vary with age, with diet, with exercise, kidney function, even genetics. So remember, with dried urine, the patient ends up being his or her own control, and you cannot adequately classify with the typical reference ranges. But it goes much further than that, because urine composition is going to differ based on what was preceding that point in time when you collected it. So if you collect a dried urine specimen at 7 or 8 o'clock in the morning, it's going to depend on what has happened during the night, because that urine needed to really get into the bladder and then out into the urine. And so it's very difficult to know, especially when you don't know what that person did and you're depending on them to give you a true nature of what they actually accomplished when they did that urine collection in the morning. So it also assumes that creatinine production in the urine is paralleling hormone output. And that has really not been addressed adequately in the literature, to say the least. In fact, almost none of the labs using this kind of dried urine spot tests, almost none of these labs have published their methodology, nor, and I'm going to be very careful here, have their results been validated independently. And if anybody has that information, I'd be very happy to see it. In fact, if you look at results from split samples, that means you take a single sample, you send it to 2 labs, one that's doing dried urine, one that's doing wet urine, or even a lab that can do both the dried and the wet. What you're going to find is actually very dramatic, because the results may differ by 3 orders of magnitude. In case of, let's say, 2 labs that are utilizing dried urine spot tests, or a lab that is doing dried urine versus 24-hour. And you say, well, how can that be? Well, I'm not going to do it today, but if somebody really wants to know, we can go into detail, because it deals with a whole number of situations with that. One of them, which is getting into the weeds of looking at gas chromatography and so on, is the derivatization of ketones. That's a big phrase, but it looks at the way in which you need to prepare the analyte in a gas chromatographic system in order to get the values that are needed. And if you're not separating out those things properly, then frankly, the results you're getting are junk. And so you need to look at that. In the absence of published methods or data, and given the small, limited urine volumes that you have in many dried urine samples for this type of analysis, it's really unclear how quantitization of certain analytes can be credibly accomplished and reproduced with confidence. And so I would say that for pulsatile analytes like this, not for all, but for this, the dried urine paradigm, or utilizing that platform, is arguably outside what one would consider as acceptable scientific standards. And I can discuss that if one would like. And so the requirements for accurate urine steroid profiling has been known for a long time. This is from Shackleton in 1985. This is not new. If you want to perfect a quantitization technique, you need accurate collection for 24 hours. You need to extract in a quantitative way all the steroids that are conjunctin in the urine. You need to hydrolyze them to separate them out properly. You need to recover, in effect, truly free steroids, etc. So we know that the literature is replete with peer-reviewed articles that compare a GCMS to LCMS for 24-hour urine samples. Some of it, by the way, is very, very beautifully done. It is a gold standard for that, that's for sure. But there are no studies that independently compare and contrast 24-hour to dried urine spot sampling. I'm talking independently. So, therefore, to end this very quick overview, what would be an ideal combination of tests if you wanted to completely assess hormone function? Well, what I would suggest is 24-hour hormone profile if you were in the business of wanting to know what is going on with the hormone and its metabolites. If that's what you're doing, if you're in hormone replacement therapy, if that's what your practice is all about, then yes, you would want to look at 24-hour hormone profile. I would say to those who are doing it, I would be a little bit concerned if you were doing it strictly with dried urine. You should be using 24-hour. If you're looking for adrenal function, especially 4-point cortisols, etc., the gold standard, I would say for that, not just it's well understood. That is saliva. That's the way in which you want to look at it. If you want to look at thyroid panels, FSH, LH, and a whole series of what we know goes on in hospitals every minute of the day, serum. That's the way in which you would look at it. Each one of these modalities has its clinical strengths, its limitations, and so a combination, yes, would be appropriate. And so the message from this is you need to know what questions do you want answered and what is the best way to approach it that is also cost effective for your patient or client. I'm just going to show you here, by the way, that there's a beautiful series of tests that were done in a Zava article. He's the head of ZRT, and back in 2015, he put all of this together to show the appropriate body fluids for testing exogenously delivered hormones. And the message here is that saliva and dried blood spot, but not serum, plasma, or urine, are really the only ways to accurately monitor exogenously produced topical steroid hormone therapy. So for most hormone therapy, which today is given topically or orally, you really do want to look at a way in which you can pick it up in a way that makes sense. Saliva is one of the ways. So comparing for endogenous hormones, what's the conclusion? All three of the body fluids are good mediums. When hormones are produced endogenously, you can pick up a pretty decent understanding both of the total and, of course, free if that's what you're looking for. But for exogenous hormones, hormones that are given synthetically, etc., in the case of serum, it's for accurate oral administration of sex hormones. If you want to use serum, you're going to need to extract and separate the metabolites in a way which is quite cost prohibitive and frankly is not the way to do it. Urine, it is not recommended unless the range is reestablished for dosing and the range is readjusted upward to reflect for the expected level. Serum and urine is not recommended for testing steroid hormones that are delivered by a topical route for administration. There, if you're going to do it, it is best with saliva. And I've given you a whole bunch of references for those who are going to want to look at it. And so that is a quick overview. I want to thank you for listening to that. And I'm ready to answer any questions that you may have. And we can also discuss some of our new tests.